that dengue fever is the most important vector-borne disease in the world. And even in this era of 2023, there is a tenfold increase over the last decade. And we know that 60% of the world's population live in dengue endemic areas. And out of that, 73% are in the Asia region, in which India is a part. And just to make you aware of the magnitude of dengue, the WHO has quoted in 2023 that about 400 billion dengue infections are there every year and about 20,000 deaths annually. And so, dengue fever is still counted in the WHO neglected tropical diseases as of January 2020. So, still it is in the group of neglected tropical disease. So, this is a global scenario, and this is the scenario in India about the magnitude of dengue infection. Now, what we have in our hands in managing a case of dengue fever is only early detection of cases, especially those cases who are going on to develop shock, and symptomatic management with fluid. These are the goals of therapy which we aim. But still, we are having difficulty in controlling the dengue. Why is it so? We know that there is no available specific treatment for dengue, like there is no specific antiviral available. And even although there are many studies towards the dengue vaccine, actually there are still conflicts regarding an effective dengue vaccine. And all the more there are difficulties in vector control. So because of all these, our only aim is to find out, pick up cases early and treat systematically with fluid management. And all of you know June is the dengue awareness month because as you know the monsoon season is robust in Kerala about June, and you know the dengue infection is transmitted by Aedes mosquitoes, and the dengue virus can remain in the Aedes mosquitoes because they are transmitted transoverally and transradially. And the eggs of these mosquitoes can contain the live virus even in very hot climates, and they can remain actually quiescent. And when there is a onset of rain, these can actually, the larvae can actually hatch out and it can become a mosquito, and that is to carry the dengue virus. So that is why we have surface of dengue infection towards the monsoon. So we are aiming in our program today for the primary and secondary care level because activities there are very critical in determining the clinical outcome of dengue. And if we are managing the frontline responses, the primary and secondary care, this will actually reduce the number of unnecessary admissions and will save the life of dengue patients. So, this is actually a dengue. WHO has put forward that in order to understand the magnitude of the problem, like even in every 20 minutes, a life is lost due to dengue. Now, I think initial a few slides that we just refreshing or recap regarding the dengue viral infection. That the epidemiological trial also aware of is a host which is having both the man and mosquito. The agent is the dengue virus, and environmental conditions also like the relative humidity etc. also to be optimum for the mosquito to multiply and virus to be the mosquitoes are the vectors which actually inject the dengue virus into our blood. So both biotic and abiotic factors in the environment is also important, and this is the dengue virus. And one thing you should know that dengue virus so far 4 serotypes have been found out. That is dengue virus 1, 2, 3, and 4. And but genotypes or subtypes are there within each serotype. So, for example, dengue virus 1 has got 3 genotypes, 2 has got 2, 3, 4, and dengue virus 4 has got 4 genotypes, and the number of genotypes is even increasing. So, actually, there is always a question of a reinfection with dengue still occurring. Now, just to make you aware about the vector breeding places, because this is very important for containing the mosquito. Because the vector is the Aedes aegypti, and you know both Aedes aegypti and Aedes albopicti. Aedes aegypti is very common in the urban population, and you can see all the industrialization, the containers, the flower pot. Because it's actually the mosquito lays egg in the clear water. So even water in the open clean water, shells, coconut shells, containers, etc. will harbor the dengue, the mosquito eggs, and that will hatch out as the larvae. And this is a Aedes albopictus, which is common in the rural setting in the vegetation, coconut shell, the tree bark hole, even even in a leaf blade of water collected can also the egg can be there and the egg will later hatch out into larvae. So you have to be aware of these dengue, the mosquito breeding places, because only if you contain the mosquitoes, the epidemic of dengue can be curbed. Now, coming to, in order to make you aware that there are many treatment guidelines which are set up by the WHO and modified according to the national. And not only India, the countries, the other Southeast Asian countries, especially Singapore, Malaysia, all those things, the Sri Lanka, they are the most Indonesia, they are the most countries and they also have their own protocol to treat dengue and all these guidelines. Name a few guidelines we have here from the early 2000 and these guidelines are definitely bringing down the case fatality rate of dengue. And just to your awareness, like in 1996, the case fatality was 3.3% and 2021 actually reduced it to 0.06% mainly because of this treatment protocol and the repeated continuing medical education program conducted to early diagnosis stage. Now, this is the latest, that is the national guideline for dengue management, dengue fever 2014, December. This is being forward by the National Vector-Borne Disease Control Program. This is the latest dengue guideline which we are following. And of late in 2020, there is also another guideline when there was the pandemic of COVID-19. There is the national guideline for dengue management during COVID-19 pandemic. These two are the reference protocols which we are referring to. Now, what is new in these guidelines? I told you the WHO and the other guidelines are there right from the early 2000, like from 1990, late 1990s. What is new in this WHO guideline is now they have classified the dengue into mild, moderate, and severe dengue. And there is something called like the expanded dengue syndrome. Called expanded dengue syndrome because in this you get isolated organ involvement without findings of capillary. Like you get dengue encephalitis, dengue myocarditis, dengue hepatitis. So there are isolated organ involvement. So the new term is incorporated as expanded dengue syndrome. Now there is another thing called metabolic dengue. This metabolic alteration syndrome and this is even classified as a severe dengue, which we will discuss in the coming slide. Then this guidelines has set the importance of early blood transfusion, and they have quoted the term like refractory hypertension, and only in such cases we need to use the inotrope. Otherwise, our main aim of treatment in dengue shock is managing the hypovolemia with very graded fluid management. And at last, the role of platelet transfusion, because once you hear the word dengue, all of you will be thinking about only the thrombocytopenia. And actually, you should remember that thrombocytopenia is not the primary cause of bleed. It's actually coming only one of the contributors of bleed. So don't panic when you get an isolated thrombocytopenia in a dengue fever. Now, just to mention the WHO classification, like they are in general, the dengue infection can be classified as be either symptomatic. Any infectious disease can have a clinical phase or it could be even subclinical. So, if the dengue infection is symptomatic and it could be asymptomatic. Asymptomatic means about 85% of the people, when they get a dengue viral infection, they are asymptomatic. That means they just have a dengue virus in the blood, but they don't manifest the clinical symptoms and signs. But these people are actually a major threat to the community because if they have a viremia, and if we have plenty of mosquitoes, the environmental factors, these mosquitoes will suck the blood containing the dengue virus from the asymptomatic patients and transmit them to other patients, and thus it will help in propagation of the epidemic. You have to understand asymptomatic dengue is very more common than the symptomatic. Now, coming to the symptomatic cases, symptomatic dengue can be either a mild dengue fever, it can be a moderate dengue fever, or it can be a severe dengue fever. So, this is the latest classification of dengue fever. Now, just to have an awareness, because why we are conducting training program is to pick up cases of dengue fever, which mainly go into dengue shocks. But as I have told you, of the symptomatic cases of dengue, about 90% of them evolve as a simple dengue, in which 50% is just presenting as an undifferentiated viral fever, is not differentiated from a usual viral infection, and sometimes it goes undetected. And other like 40% of them will present with the classic clinical signs of a dengue fever with severe headache, intraorbital pain, myalgia, arthralgia, rashes. So that means 90% of them will be just like a dengue fever. They are usually not going into the capillary route. But 10% of them present with dengue hemorrhagic fever, and out of that, 1%, 1 to 2% are the people who manifest in clinical pictures of dengue shocks. This is the magnitude which you should. Now, I think I need to explain more what is a primary dengue. You have 4 serotypes of dengue. And if you have a dengue viral infection for the first time with a particular serotype, it is called as a primary dengue. And usually, primary dengue will not go into the capillary dengue, the increased capillary permeability, that is called as the dengue vascular permeability syndrome and dengue shock. But of late, there are studies that even show that even a primary dengue can sometimes go into capillary leak, which I will be showing in the next slide. Now, all of you are aware the dengue which manifests as capillary leak and dengue shock syndrome is the secondary dengue. And you know what is secondary dengue? You already have a serotype virus infected, might be years back, and you have suppose you are infected with dengue virus type 1, your body will have antibodies against the dengue virus type 1, which are the neutralizing antibodies, but your body will also contain cross-reacting antibodies against the other dengue serotype. If you have a second infection with a different dengue serotype, the already present antibody will enhance, that is the antibody dependent enhancement, which will facilitate faster viral entry into the cell, and that will cause cytokine release and inflammatory mediator and inflammation, and that will set up a cytokine tsunami like thing. And that is the thing which is causing the capillary leak and the vascular permeability. Now, so briefly, like what we mean by your dengue vascular permeability syndrome is the antigen antibody, or what is it, the antibody dependent enhancement. That is, when there is a heterotypic antibody dependent enhancement occur, which will facilitate viral entry and multiplication in the monocytes and macrophage. That will cause release of inflammatory mediators and what is called as a cytokine cascade or tsunami, where within the vascular endothelium, it will cause an endothelial dysfunction, increase the vascular permeability, and it will cause leak of fluid from within the intravascular compartment, giving rise to hypovolemia. There are other mechanisms like complement activation mechanisms and activation of memory T cells, which will also cause release of inflammatory mediators and ultimately helping in the cytokine tsunami. So this is the pathogenesis of a secondary dengue. So earlier I told you, even a primary dengue called as a dengue toxicosis, that also can set up a release of inflammatory mediators, and that is being recently got quoted by a PubMed article in 2015. That means this endothelial dysfunction and this vascular permeability could also be sometimes caused by a primary dengue viral infection. Okay. Now we'll come into the what are the phases of dengue virus. I think viral infection, which all of you are aware of. The dengue viral infection has got a time frame. You know about the time frame of the COVID-19 infection, which we are aware of. Similarly, dengue viral infection also has a time. So the usual incubation period, the maximum incubation period is like the period from which you have a bite of a Aedes aegypti mosquito carrying the dengue virus, and time taken for the symptoms to manifest is ranging from 4 to 10 days, but it could be as high as 2 weeks. Then, after the incubation period, you have the clinical manifestation. The first phase is the febrile phase that can last from 2 days to 7 days. So this is important because usually in the febrile phase, this patient will not go into the capillary permeability syndrome, and the leak is not occurring in the febrile phase. So once the febrile phase over, it is succeeded by the critical phase in which the vascular permeability increases and there is peak of intravascular, that is the plasma leakage which occurs, which will give rise to depletion of intravascular volume and features of hypovolemia. And because it is a leak, you have fluid collection in the interstitial compartment, which will give rise to ascites, pleural effusion, edema. And the third phase is the recovery phase, and this phase follows the critical phase, and that phase will last 48 to 72 hours. One thing which I have to concentrate here is since the febrile phase lasts from 2 to 7 days, the onset of critical phase can be as early as the third day or as late as the eighth day. But once the patient goes into the critical phase, although desperate description is for 24 to 48 days, we have seen over time that the critical phase can even prolong to even more than 1 week. So this depends upon the investigations and the other things which we clinically and laboratory based correlate from the patient. So critical phase can even extend beyond 1 week, and then it is followed by the recovery phase. And so this is again the febrile phase, 2 to 7 days, critical phase, and then the recovery phase. Here, let me tell you one thing that what we have told is okay, then this is the febrile phase, the incubation period, and after the incubation period, the patient presents with sudden onset of high-grade fever, and I told you it usually lasts for 2 to 7 days, and this is the classic presentation of a classical dengue fever, like the patient or a child can present with headache, throat pain, myalgia, arthralgia, macular papular rash. There will be what is called as a generalized flushing, and even you can get hemorrhagic manifestation. So this is the classic presentation of a dengue fever, which I told you is seen in 40% of cases, but 50% of cases they will just present as an undifferentiated viral fever. Now, febrile phase, if you have a laboratory investigation, you will understand that leukopenia is the earliest abnormality. If you have a baseline leukocyte count, that progressive decrease in the total leukocyte count is the earliest abnormality, and that is followed by the abrupt decrease in the platelet count. And this is actually the tunicate. That is, a tunicate test if you do has got an increased probability of diagnosing dengue, but actually it is not very much favored and it's very difficult to be done in children. For completion sake, I have told about the tunicate test, and this is the tunicate test which you do. That is, after recording the blood pressure between the systolic and diastolic blood pressure, you keep the pressure elevated for 5 minutes and then deflate the cuff, and you will measure, you will count the number of petechiae in the 1 inch area in the cubital fossa, and if there is more than 10 petechiae, it's taken as the probability of dengue. So this is not very much favored because of the time problem and difficulty. So this is just to show picture showing the generalized flushing which we see in dengue. Now, when the patient actually goes into the critical phase, most of them, the fever is going to come down, the temperature is becoming ephemeral, and this progressive leukopenia is there. And then, because the vascular permeability has set up, the patient will go into hemoconcentration, and there will also be an abrupt fall in the platelet count. So, hemoconcentration, progressive leukopenia, followed by hemoconcentration and abrupt fall in platelet count, along with an ephemeral phase, is heralding the onset of the critical phase. And due to the increased capillary permeability, significant plasma leakage is seen, and that is causing, I described earlier, hypovolemia, hypotension, and fluid collections, pleural effusion, and diarrhea. And now, recovery phase, what happens is this is very important when you manage dengue because I told you the main problem in dengue viral infection is this cytokine tsunami is going to lead to what is called as an endothelial dysfunction. Since your ocular endothelium is dysfunction, the leak occurs in the critical phase. But what happens in the recovery phase is that this endothelial dysfunction is gradually recovered. So when the endothelial dysfunction recovers, whatever fluid has extravasated into the interstitial compartment will now come inside the intravascular compartment. So if you are not very careful about your fluid management, if you had given excess fluid either in the febrile or in the critical phase, these excess fluid would have stagnated in the interstitial compartment and that come in the intravascular compartment in the recovery phase, which will create problems of increased intravascular volume and even the patient can manifest cardiac failure. So because of that, we give judicious fluid administration. So when there is a gradual improvement, your hemoconcentration will stabilize, the total count will begin to rise, and the platelet count will also begin to increase. And a general well-being will occur with the child. And the mnemonic ABCD is for the recovery phase, in which A is the appetite is returning. B, usually you get a bradycardia because when there is intravascular volume depletion, there will be tachycardia. But when the volume is depleted, you get a bradycardia that heralds the hemodynamic status is stabilized. Then C is for a convalescent rash, which I think most of you would have seen. It's like islets of white with the T of red. And D is the diuresis. This is again because whatever fluid has leaked into the interstitial space is coming back into the intravascular compartment. That is causing an increased urine output in the recoveries. So now we'll come to the what is called as the dengue hemorrhagic. So in order to call a dengue hemorrhagic fever, you have to satisfy four criteria. One is that particular child should fit into the clinical criteria of dengue fever, which I have told earlier. That is a fever which is lasts for at least 6 to 7 days with the classic presentation of headache or with pain, arthralgia, myalgia, or a rash or a bleeding manifestation. So that is the clinical criteria of dengue fever. Second criteria is the child should have a hemorrhagic tendency. And this hemorrhagic tendency can be either with a positive tunicate test alone, or it could be like having mild skin plaque in the form of petechiae or ecchymosis, or it could be a bleeding from the mucosa, like from the gastrointestinal site or the injection. So that is the second criteria, hemorrhagic tendency. The third criteria is there should be a proper cytopenia, which is usually less than 1 lakh, and there should be evidence of plasma leakage. And the evidence of plasma leakage is mainly by either there should be a rise in the average hematocrit of more than 20%, but that usually it will be difficult if you don't have a baseline hematocrit. So, retrospectively, we'll know that whether there was a drop in the hematocrit with our fluid management, or there are signs of plasma leakage like pleural effusion or a so these are the four criteria which are needed to satisfy the definition of dengue hemorrhagic fever. That is, the child should fit in with the clinical criteria of dengue fever. There should be hemorrhagic tendency, there should be thrombocytopenia, and there should be evidence of plasma leakage. So now, how is it classified? The grades of dengue hemorrhagic fever. You have a dengue hemorrhagic fever 1 if there is only a positive indicator. You have a grade 2 if you have a spontaneous skin or mucous membrane bleed. Dengue hemorrhagic fever 3 is when you have features of circulatory failure. So that is usually when you have a tachycardia or a low volume pulse pressure is less than 20, or you have hypotension, cold climate, extremities, and restlessness. So DSM-4 is you have profound drop with undetectable blood pressure. So that is the 4 grades of dengue hemorrhagic fever. So you mind you, when you have a dengue hemorrhagic fever 4, this means you don't have even a detectable pulse. And dengue hemorrhagic fever 3 and 4 together is taken as a dengue shock syndrome. Now, what is a mild dengue fever, which I have already told you? In mild dengue fever, it is either as an undifferentiated dengue fever, which is difficult to differentiate from an ordinary viral fever, or it can be a classic dengue fever like the symptoms which I have already discussed. Now, coming to what is the moderate dengue. Moderate dengue fever is a dengue fever with a high risk comorbid conditions. So any dengue fever in a child with an associated comorbid condition will go under moderate dengue. The next is moderate dengue fever, as you all know, is a dengue fever with signs and symptoms. What are they? What we classically call the warning signs and symptoms of dengue fever, and which you all should be very much aware of, because these are the signs and symptoms by which we are picking up an early capillary. So what are they? They are the recurrent vomiting, they are the persistent abdominal pain or tenderness, generalized lethargy and restlessness. You get minor mucocutaneous bleed, and there could be mild pleural effusion ascites, there could be hepatomegaly, and because of the leak, there is an increasing hematocrit and a decreasing platelet count. So these are the warning signs and symptoms which be very much aware of, because you have to pick up a child with these warning signs and symptoms and immediately start the child on fluid pressure measures to increase the intravascular flow. So this is very important. And what is severe dengue? So the term severe dengue in WHO 2014 is any dengue with a significant hemorrhage. Any dengue with a massive significant hemorrhage is a severe dengue. A dengue fever, which I have already told you, dengue hemorrhagic fever 3 and 4 with shock, that is a dengue shock syndrome, that is a severe dengue. I already told you some of the dengue, severe dengue, need not have capillary leak, evidence of capillary leak in the form of hemoconcentration or thrombocytopenia. Here, the dengue viral mediated direct mechanisms or the immunological mechanisms are directly injuring your organ. So you get an isolated organ involvement in the form of dengue myocarditis or dengue encephalitis or dengue hepatitis, and out of this, dengue myocarditis is having a very high mortality. So even dengue encephalitis, but some of them recover, and those recovering from encephalitis, majority of them will go into neurological treatment. So hope you have understood. Expanded dengue syndrome is the solely the severe organ involvement which is seen in dengue without evidence of capillary leak. Now, next is I have already told you the dengue fever is associated with metabolic and electrolyte abnormalities like hyponatremia, hypokalemia, or hypoalbuminemia, or a metabolic acidosis. All these are also grouped under severe dengue, because dengue with all these metabolic disturbances are having a poor outcome. So these are the severe dengue. So just to discuss about the expanded dengue syndrome, it can involve any organ. As I already told you, it can involve the central nervous system. It can involve the gastrointestinal, like hepatitis and fulminant failures. And you know, acalculous polycystitis, the commonest presentation. And you even do a point of care ultrasound. And if you find a dilation of extended gallbladder, that itself is taken as an evidence of early leak. And renal involvement in the form of acute renal failure. Cardiac involvement, as I told you, it would be like a cardiac dysfunction giving rise to shock or cardiac failure. And more commonly, even you see cardiac arrhythmias, you see first degree, second degree blocks, and respiratory. The typical respiratory is since you get ARDS picture, cardiac pulmonary edema, and in the eye also they have retinal hemorrhage, macular hemorrhage, and these are the isolated organ manifestations in dengue. So this is also grouped under severe dengue. And you might also have seen cases of dengue which actually lands up in the pediatric surgery department as a case of acute abdomen. Why? Because I told you in the warning sign, intense abdominal pain is a warning sign. So this intense abdominal pain, and when you clinically examine the child, uh, you might diagnose that the abdomen is board-like rigidity and there is tenderness, and sometimes there could be a suspicion of an acute abdomen. This is mainly because once the leak has started, there is what we call as transit vasoconstriction which is occurring, or the leaked fluid is actually going the the pararenal and perirenal area, and that is causing a reflex record pain in the epigastrium. So, acute abdomen, pediatric surgery, consultation and pediatric surgery, what the children can do, how you diagnose these cases. When you do a CBC, instead of getting a neutrophil, leukocytosis and neutrophilia, and a normal hemoglobin in an acute abdomen, if it is a dengue, you will mainly catch hold of the children because see that there is a progressive leukopenia or a thrombocytopenia or there will be evidence of hemoconfirmation. So you have to be very aware of a dengue warning sign presenting as an acute abdomen in the pediatric surgery department. Okay, so this is just to reinforce what I have told. The primary event in the pathogenesis of dengue, that is the dengue vascular permeability syndrome, which we call, is due to an endothelial dysfunction which is occurring. So this endothelial dysfunction is causing a increased capillary permeability and leak of fluid from the intravascular compartment. So that itself is causing a vasculopathy because it is an endothelial damage. And because of the endothelial damage and because of the capillary leak of the fluid, there is a hypovolemia which is decreasing the blood and oxygen to the tissue, which is producing a metabolic acidosis. And the acidosis will trigger a DIC or a coagulopathy. And because the dengue virus is directly depressing the platelet production in the bone marrow, or more commonly because of what is called as endothelial sequestration of platelet, because again the endothelium is the primary target. So increased amount of platelets will be sequestrated in the endothelium, which is causing a thrombocytopenia, that is a quantitative effect. There could also be qualitative effects occurring in the platelet. And as I have told you, an isolated organ damage. So these are the different pathogenic mechanisms which are actually leading to shock, bleeding, and organ damage, which is seen in dengue. I hope that is clear. So this single slide explains in nutshell about the pathogenesis and the outcome of a dengue viral infection. Okay, so now we are more bothered about dengue fever, which is causing a dengue vascular permeability syndrome and causing leak of fluid outside the vascular compartment, leading to dengue shock. So, the onset of shock is usually at the critical phase when the fever abates, and once the shock has its onset, it has got a relentless progression. And why children it's more complicated than in adult because there is the microvascular permeability is intrinsically higher in children. So children are more prone for capillary leakage and dengue shock. And one important thing which you have to register in your mind is the main cause of bleeding and the main cause of multi-organ dysfunction syndrome, which you see in dengue viral infection, is the shock. The shock, which is resulting due to hypovolemia or might be because of a cardiogenic element. The shock, if it is getting prolonged, that is leading to metabolic acidosis. And the acidosis is triggering your coagulopathy or DIC. And that is the main reason for severe hemorrhage in dengue, and that is the main cause for mortality. So this point you have to go on in mind, and it is not because of the platelet defects causing the bleed or the mortality. Now, so what we know now is with proper resuscitation and supportive therapy with fluid, mainly with fluid, the case fatality, we are able to bring down to less than 0.1 percentage, and as I told you earlier, it has even come down to 0.06 percentage. So these are the two pillars in management of dengue shock. So what are they? One is you have to early identify and recognize the shock. So that is very important. And second pillar is once you recognize the shock, you have to timely manage with it. So these are the two pillars in the fruitful management of a dengue shock. Now we'll come to discuss about each one of them. So how do you early identify a shock? So that is why I have earlier discussed the warn. What is a warn? You are going to pick up a child with the warning sign. So the onset warning signs indicate that the capillary leak has started, and now the fluid has started to extravasate from your intravascular compartment into your interstitial space. So you have to diagnose the warning sign, and you have to pick up a child at the warning sign stage, and you have to rehydrate the child very immediately. If you are not picking up a child at the warning sign, what happens is these children will go into compensated shock. So compensated shock will occur when more amount of fluid has extravasated, and now the intravascular volume has depleted, and now your capillary perfusion has become low, your peripheries are cool, but your BP is maintained. So that is a compensated shock. And then if you are not picking up a child in the compensated shock also, the child is going to deteriorate into the decompensated or a hypotensive shock, which is having a very high mortality and morbidity. So this is the early identification of shock which you have to be aware of, and you have to pick up a child in the warning sign. Now this is the warning sign which I have already told just for your record. Now what is the second pillar? The second pillar is once you have identified that the leak has occurred, you have to timely manage with fluid. You have to timely manage with fluid because fluid therapy is the only treatment which you can give to save the life. So that is called as the fluid expansion and the supportive therapy. And you know, if appropriate volume resuscitation is started, you know, shock is you will not allow the child drift into like from the warning sign, compensated shock to decompensated or the hypotensive shock, and ultimately to irreversible shock and ultimately death. So that is more important. So first pillar is you have to identify the time that is of a capillary leak by picking up a child at the warning sign. Second is you have to start initial fluid therapy. These are the two things. So now coming to the fluid management in dengue, which is very important. So you have to be thorough with the fluid management, the options available, which fluid to be given, how fast to be given. So you know that it's the only effective treatment in a dengue shock syndrome, which is resulting into increased vascular permeability. So I told you what is the reason for the vascular permeability increase? It is the endothelial dysfunction. And I told you in the critical phase, the endothelial dysfunction causing the leak. And what happens in the recovery phase? When the endothelium recovers, all the fluid will come back into the intravascular space from the interstitial. So you have to be very careful. You have to give fluid in the leaky phase or the critical phase just enough to maintain a minimum urine output and just enough to keep the hemodynamic status okay. Any excess of fluid you are going to give will again leak into the interstitial space and it will add on in the interstitial space. And what happens in the recovery phase when the endothelium recovers, this all the fluid in the interstitial space going to come back into the intravascular compartment and a child whom you have survived in the critical phase might die due to the increased intravascular volume and cardiac failure in the recovery phase. So if you know this concept, this is very important and crucial in managing a dengue shock child. So what is the timely fluid and judicious fluid resuscitation? As I told you, you give only that much amount of fluid which is able to maintain a stable hemodynamic status. Like the patient has got, if the patient had a tachycardia, the pulse should come down. The pulse volume should improve. The hematocrit should improve. And you are aiming at only a minimum urine output of 1 ml per kg per hour. So if you are getting, by the fluid resuscitation, you are getting a urine output like more than 1 ml or even 3 to 4 ml per kg per hour, that means that you are giving fluids in excess. Whatever fluids you give in excess will leak fully into the interstitial compartment and everything is going to come back in the recovery phase and will cause trouble. So the prime aim in the fluid management in dengue is to prevent the fluid overload from. I hope it's understood. So now we'll come to what is the choice of fluid in dengue. You know, you can give a crystalloid, you can give a colloid, and you can even give blood. And as I told you in the 2015 guidelines of WHO, the indications for blood transfusion in dengue has become a major point, and this indeed has saved a lot of lives even in our hospital. So you should know when to give steroid, when to give colloid, and when what are the indications of a blood. So I think don't think this will look too complex. Just have a look at the figures. Look at the first figure. What does the first figure show? You should understand when you want to understand about the fluid management. You should understand that our body is made up of 60% of water. So in the 60% water, 40% is intracellular, which I have shown in the yellow. Just concentrate on the first figure. The yellow color is the intracellular fluid, which is 40%, and the red and blue together is the extracellular fluid, which is 20%. And your red is the 5%, which is the blood. So that is the normal distribution of intravascular and extravascular fluid. Now look at the second figure. If you are giving, like you are giving a dextrose container, like you're giving a 5% dextrose, 20% dextrose, what will happen is that the entire thing is going to distribute equally in the like in the intracellular and extracellular, and only if you are giving 1 liter of dextrose, only 83 ml is going to retain in the intravascular, that is blood. Just see the red. Now, if you are going to give isotonic saline, about 300, 1 liter of isotonic saline you are giving, 300 ml is going to retain in the blood. Okay. Still, you should understand 700 ml is remaining in the interstitial compartment. Now, consider colloids in blood. If you give 1 liter, almost everything is going to retain within the intravascular compartment. So now you would have understood what is the choice of fluid which you will give. So the choice of fluid, if you are giving, which one remains 10%, that is a dextrose containing. So there is no place that you give a 10% dextrose or a 5% dextrose when there is an intravascular volume depletion. You shouldn't give. Now, what we give, our choice of crystalloid, even though we give crystalloid, only 25% is remaining in the intravascular. What does it mean? The rest is in the interstitial. But if you are giving blood or colloid, theoretically, we feel that about almost 100% is going to remain in the intravascular compartment. But mind you, one thing you have to be very clear that even though you feel that the colloids are going to remain 100% intravascular, In cases of dengue, vascular permeability syndrome, because of the increased capillary permeability, the colloids you are going to give is also not going to retain full. So some amount of colloid is also going to leak out, which we'll be discussing in our coming slides. Okay. So now crystalloid. What is the crystalloid of fluid? So if you have a dengue vascular permeability child and you are picking up the child at the warning sign, which means that the extravasation has increased, the crystalloid of choice is normal saline. Now, why do you prefer normal saline? You know, normal saline 164 milliequivalent sodium and 154 milliequivalent chloride. And so, the higher the sodium, the better the plasma volume expanding capacity. So, that is the important. But the disadvantage is that if you give lot of sodium chloride, there is always a possibility of a hyperchloremic acidosis. And as I have told you, acidosis is the main event which is causing a coagulopathy and the bleed. So you have to be careful to give a lot of normal saline. But somebody asked you which is a lot of choice in a dengue warning sign or a dengue shock, it's always normal saline. But if don't have normal saline, you are left with only ringer lactate. You can give ringer lactate, but you know the sodium content of ringer lactate is 131, which has got lower sodium compared to normal saline. So the plasma expanding capacity is not as good as the normal saline. And moreover, the ringer lactate, since it is lactate, there could be accumulation of lactate and worsening of tissue acidosis, especially if you don't have a good blood supply to the liver, because lactate conversion to bicarbonate occurs in the liver. So again, you don't want acidosis to worsen, because acidosis is the main thing which is going on to a bleed. And as I have told you, always avoid dextrose containing fluids and hypotonic fluids, because dextrose containing fluids, I told you, is not going to reach within the intravascular compartment. Hypotonic fluids like isop is going to, the sodium content is low. It's only 1/5 the saline. Sodium content is only 30. So you are going to create more leak from the intravascular compartment. So I think it is clear the preferred crystalloid is normal saline. You should not give any hypotonic fluids or dextrose containing preparation. Now, coming to crystalloids, it is you all have to know that the choice crystalloid, the standard or what you call like gold standard crystalloid, which can be what is called as a plasmalite. It is a balanced electrolyte solution. Why it is called balanced? The sodium chloride and the osmolarity are almost similar to the plasma. So sodium is 140, chloride is 98, and osmolarity is 280. So that is going to be the best crystalloid in dengue, but it is not available in our health government sector. So we are resorting to normal saline, but the disadvantage is the chloride will be higher than 164. And if you give so much of normal saline, sometimes it can give rise to hyperchloremic acid. So plasmalite is the crystalloid of choice because it has got same concentration to the plasma. And of course, some cases of severe dengue in our center, in our ICU, we ought to even resort to 5% albumin, because even 5% albumin means 5 gram in 100 ml. It is almost similar to the plasma albumin concentration. So this is called as resuscitative albumin. If 5% is not there, sometimes even 20% albumin can be given, but give it with caution, especially in those children in which you are suspecting a cardiogenic shock. Okay, so now crystalloid is over. Next we'll come to colloid. So all of you are aware what is a colloid? In a colloid, the molecules are larger, so they can retain in the vascular compartment for longer time. So it is 3 times more effective than crystalloids as plasma expands. Clear. And this will expand the volume in excess of the actual volume administered. And so, if you have a child with a hypovolemic shock and you want to have a rapid restitution of the intravascular volume, you prefer the colloid. But colloid has got its own limitations because colloid cannot replace the blood because colloid does not have RBC and it doesn't have hemoglobin which can carry the oxygen. Because I told you metabolic acidosis will be cleared only sometime when you give blood in cases indicated because blood contains hemoglobin that will carry the oxygen to the cells and that will enhance the aerobic TCA cycle and that will liberate more ATP. It will curtail the anaerobic oxidation of the lactic acid. So when blood is to be given, you have to give blood. Colloids are not a substitute for it. And even colloids will not contain the plasma proteins and it will lack the clotting factors, especially in a setup of coagulopathy where we need to give fresh frozen plasma. And as an albumin, colloid also has to be given in concert with cardiac function because the retaining capacity intravascular is sudden, so it can sometimes precipitate cardiac failure. So I have told about crystalloids and colloids. Now we all see when we actually hear dengue, we are worried about a bleeding child in dengue, and that is the most dreaded thing which we should not uh, aim at. Means a bleeding in dengue, and as I already told, it's not the platelet is not the concern. So don't consider thrombocytopenia as a cause of bleeding. So what are the causes of bleeding? It is multifactorial, and as I have told you, the main cause of bleeding is the prolonged shock. So that is why now you would have understood. We should not allow a child to drift into shock. We have to catch the child early, even in the morning time stage, and we have to replete the intravascular volume so that the child does not drift into shock. Shock causing metabolic acidosis, metabolic acidosis, coagulopathy, and bleed. So that is the major cause of bleed. The other factors like vasculopathy, the coagulopathy, even qualitative and quantitative effects, platelet, hepatic derangement, hepatic failure, all will act synergistically to cause bleed. But you should understand the main cause of bleeding is prolonged shock, which we should treat by judicious administration of. So this is already I have told you. Now, this is very important. Which case of dengue you need to give blood transfusion? So blood transfusion has really decreased the mortality and morbidity to a very great extent, especially after the indications of blood transfusion in the 2015 protocol of WHO. So, of course, if you have a child who is severely bleeding, blood transfusion is mandatory. Second indication is you have a dengue child and it is a hypotensive shock and you see that is a hematocrit on the lower side. Usually what should happen if the capillary permeability is increased, the intravascular volume leaks out, so you expect a hemoconcentration. But if you get a hypotensive shock with the low hematocrit, that itself signifies that even though you cannot see the bleed, there is an occult bleeding inside, and that is also an indication for blood transfusion. Now, the third indication is suppose you have a patient in a shock, dengue shock, and you have rehydrated or given judiciously the crystalloid and colloids, but after some few hours, if we find that the hematocrit is decreased and the shock is also persistent. So that means that again there is a bleed, so you have to give blood transfusion. Now, fourth indication is you have a shock child and you are judiciously given steroids and even colloids is indicated, and you check the hematocrit, you see that the hematocrit is either the same or the hematocrit is a bit increased, but you have a persisting shock. So that also means that there is a occult bleeding and you ought to give blood transfusion in such case. And the last indication is you give all your measures like give crystalloids, you give colloids, you correct the other correctable causes, but still you do a VBG or a witness blood gas, we'll find that there is a worsening acidosis. So as I told you, worsening acidosis means worsening lactic acidosis, which is due to the anaerobic cycle glycolysis which is taking place. So, only blood which contains RBC, which contains hemoglobin, that will transport oxygen to the tissues and that will stop the anaerobic glycolysis and the aerobic BCA cycle is the and it will result in decrease the acidosis because I have told you acidosis is a major cause of bleed. So these are the indications for blood transfusion. I think you will understand better when I discuss the scenarios in the coming session. Okay. So now you see, whenever we have a early peak in dengue now, so once there is a dengue infection and we actually the transfusion medicine department is actually saturated. Like we order for all the blood products, blood platelets, fresh frozen plasma. But we have to be very judicious and we have to have clear-cut indications in which case you ought to give blood and which case you need to give the other blood products. So you shouldn't flood the transfusion services with blood and your components. You have to have clear indication. Now, this too is very important. What are the indications of platelet transfusion? So, as I have told earlier, thrombocytopenia is not a cause of, not a major cause of bleed or major cause of mortality. And we had our own study in our pediatric intensive care unit. And actually, we had taken the statistics of the dengue deaths there. And the average platelet count of the dengue death children were 68,000, which means that thrombocytopenia is not a major factor which is the mortality of children. And as I have told you, the main factor is uncorrected shock, prolonged shock, refractory shock, which is leading to metabolic acidosis, coagulopathy. So you have to be very strict in your platelet transfusion indication. Of course, when the platelet count is less than 10,000, there is a chance of bleed even in normal children. So prophylactic platelet transfusion is indicated. Okay. Now the second indication is you have a dengue child as blood. So definitely the dengue bleeding dengue child you have to replace everything. But mind you, in this scenario also, the first blood component which gives blood. Because as I have told you, blood is a thing which contains RBC and hemoglobin and is going to carry oxygen to the tissues and curtail the metabolic acids. So in a bleeding child also, first thing you have to give blood and then only you need to order for the platelet because you know platelets are active only when they are kept in an agitator. If you buy the platelet early and keep in your ward, the platelet will lose their function because it's removed out of the agitator. So once you have given blood, you give it by giving the platelets, and even if the coagulopathy parameters PINR is prolonged, you ought to give the fresh frozen plasma only. So this is the second indication for platelet. And third indication, you have a child who is having a prolonged shock, and you laboratory investigations are showing that it's the DIC like picture coagulopathy with a patient is having PTINR, APGP prolonged, that child is also prone to develop a hemorrhage or a bleed, so you ought to give platelet transfusion. So these are only are the three indications for platelet transfusion in dengue. Because unnecessary platelet transfusion, unnecessary fresh frozen plasma in dengue, what it will cause, you are giving these things in the intravascular compartment, the capillaries are leaked. This will simply, to some extent, will leak out and it will add to the fluid in the interstitial compartment. And in the recovery, this fluid will again come back into the intravascular compartment. So you ought to limit the intravascular fluid you are giving by keeping clear-cut indications for the blood and blood product transfusion. So I hope it is clear. Now, two slides regarding dengue and heart because dengue myocarditis, dengue arrhythmias, they are the major cause of mortality in children. And even in our hospital, 2013 epidemic, 2017 epidemic, all the in these two epidemics also, more than 60% of the children who had died had a dengue myocarditis. And the incidence is also high. The studies are showing from 8% to 27%, but at least uh, about one-fifth of the cases have got dengue myocarditis, and it is an important cause of mortality. And the involvement of the myocardium can be symptomatic, mildly symptomatic, or it can proceed with a pulmonary myocarditis. And I told you in the dengue management algorithm, you give fluids, if the myocardium is failing, the excess of fluids cannot be pumped out by the heart. So even a mildly symptomatic myocarditis become manifest when you give fluids. So that is how you pick up, and such children will need inotrope also to be administered. And it can manifest as refractory shock or congestive cardiac failure or even as rhythm disturbance. Okay, one another notion is like you feel that when the patient is having dengue myocarditis, send the biochemical markers, it will be elevated. No, because it's a functional myocardial failure occurring because of the myocardial interstitial edema. So the myocardial cells are not injured, so the troponin T and I will not be elevated. And you have to give due consideration to hypocalcemia and hypokalemia because both of them, hypocalcemia, hypokalemia, hyperkalemia, they all are depressing to the heart. So you have to manage hypocalcemia, manage hypokalemia and hyperkalemia accordingly. So there is no myocardial necrosis or injury. Myocardial interstitial edema might be causing myocarditis. So biochemical markers will not be elevated. So as I have told, this will have implications for fluid management because if the patient is having an element of myocarditis, he will not tolerate the fluid you are giving. So this is actually a very difficult patient to titrate your fluid and inotrope when the patient has got both the capillary leak and the myocarditis. It really needs lot of monitoring and hourly monitoring and hourly investigation, bedside IV measurement, etc., to manage such a child. Okay, so I think with all these initial uh, things about dengue, you have an overview of what you should do in a dengue shot. Now we'll come to a set of scenarios. Okay, so this is a scenario one. So this is a 5-year-old child who has come with a high-grade fever, myalgia, and headache. And on examination, his febrile, temperature is 103 Fahrenheit, pulse is 134, that is tachycardia, but the pulse is good body. Okay, the capillary filling time is less than 2 seconds, and a 5-year-old child is having a BP of 80 by 50 now. And the dengue NS1 was done from the primary level hospital and it was turned out to be positive. So this is the scenario in which a child has come to 5-year-old child presenting with almost like a classic, like high grade fever, myalgia, headache, high grade temperature, tachycardia, but there is no evidence of a shock. That is, the pulse volume is good, capillary filling time is good, and the BP is also minimal. So now, what are you going to do with this child? So you send the investigation. You found that the hemoglobin was 11, the Pascal volume was 33. So average Indian children. This is not unless the child has an underlying anemia. There is no hemoconcentration, and the total leukocyte count came out to be 3,500, and the platelet count is 0.3 lakh. So how are you going to do? Because it is a common scenario which you will be encountering, and it's not possible that you have to admit all. It's not possible to admit all children with a dengue NS1 or a dengue IgM positive to your hospital because there will be scarcity of bed and even the manpower to monitor them properly. So what you will do with such a child? So how do you manage? So this is a child who is having a dengue fever, but he is not also not having even dengue warning sign. So this child will ideally require only an outpatient management. So the child requires adequate nurse. You need to titrate the paracetamol. Although you know paracetamol dose is 15 mg, the protocol guidelines actually tell them to restrict to 10 mg per kg per dose hourly, and you are avoiding aspirin, ibuprofen, other NSAIDs, steroids, all those should be avoided. And you ought to counsel the mother and the child to take a regular diet, plenty of fluid, rich in electrolytes. This is very important because I told you, simply drinking plain water or hypotonic fluid will not serve the purpose of keeping the intravascular volume already. This child is only in the febrile phase, but still, if metabolic abnormalities come in this dengue, like a hyponatremia, hypokalemia, which can come due to vomiting, this child will again go into the classification of a severe dengue. So regular diet with semi-solid or solid, whatever is palatable, with plenty of fluid rich in electrolyte have to be taken. And preferably, if there is mosquito net, you can call the other person in the house or the neighborhood can we need in get, and you can find out where the mosquito breeding places are and you have to eliminate. See, this is also included under the management because mosquitoes are the main vectors transmitting the virus. You ought to give importance to even looking at the breeding places, and you have to might be it is a flower pot kept inside the house, water logging in the flower pot is causing the mosquito to lay down eggs and the larvae coming. And the last one which I have highlighted in red, IV fluids in case of persistent vomiting or occasional repeat. Will you give IV fluids to such a child who is in this febrile phase of dengue? So, some children will be having high fever, some children will vomit because of high fever, they will be refusal to feed. But as far as possible, try to give them small liquids of fluid, electrolyte fluid, even ORS can be given frequently. So that is the main aim, to rehydrate them orally. Suppose they are not taking orally, you can put an IV fluid like a maintenance PNS. But what you want to do is you have to limit the fluid you are giving. You limit it to 1.5 ml per kg per hour. That means just remember the usual maintenance fluid requirement will come to 3 to 4 ml per kg per hour. So you need to just give half of that, 1.5 ml per kg per hour. Or if you take it in per day, like a 10 kg child who requires like a maintenance of 1000 will require only 500. And mind you, don't put it over 4 hours or 6 hours. That is why I am telling the dose hourly. You put for 1 hour, then look whether he's improved, like he's able to take orally. As soon as he takes orally, you have to switch over from IV to. So that means even in the febrile phase, try avoid giving an IV fluid to a child unnecessarily. So this is one of the important steps. Is it clear? Now, so what is it? The key to success of an ambulatory or an OP management is to give a good advice on care at home. So you want to educate and communicate to the mother, tell her about the disease, that is the time frame of dengue, and you should tell her about the febrile phase. The child becomes febrile, she has to be more careful, and you have to counsel her on what all warning signs she has to be aware of, and tell her to report to the hospital immediately if there is any problem. So this is also very important. Why I'm stressing on this point is, in the dengue epidemic era of 2017 and later, we had many big children like 10 years, 12 years coming to us practically even with absent pulse. Absent pulse. I'm very serious about it. Even children with absent pulse, feeble pulse, 10 to 12-year-old children were coming to us because these children were having fever for 3 to 4 days, treatment as a local hospital. When the fever abates, the mother is not able to pick up. Like when these children become febrile, they have excessive lethargy, they are not taking anything orally. Big children, so mothers are even hesitant to bring to the hospital. And these children are ultimately brought to our hospital in a very bad condition, in which even the pulse was not there, and that is found shock. So this has to be avoided. So this is possible only if you counsel the mother regarding the danger signs. So you have to educate the mother regarding the transition from the febrile to the febrile period. Tell her what you have to be aware of, the onset of warning sign. കാരണം മിക്ക warning sign കൈ കാല് തണുത്തിരിക്കുന്നു, lethargy, fatigue, ഇതാണ് predominant cause. So you tell them when the fever is gone, if the child is not well, looks like not able to see, peripheries are cold, and the child is always sleeping and lethargy, tell her you shouldn't deny coming to the hospital even it's middle of night or a Sunday. Take the child immediately to the hospital. So you should counsel her. So the first scenario is simply a case of dengue fever in the febrile phase, but you can send the patient outpatient as an ambulatory management, but you have to give a thorough education to the mother. And especially if he's in a setup nearby to a community health center or a primary health center, you can tell the mother to do a hematocrit and a platelet daily, and also when he's effervescency, you can also repeat. So that will also pick up whether he is going into the critical phase by an increasing hematocrit or a sudden thrombocytopenia. So this is very important. So this action plan or the card listing of home management of dengue, this I have taken from our own Kerala government's dengue management protocol by the vector-borne diseases. There is a paper on one of the paper in the last page, right? And I am going to just expand on it in the coming slide. So, what is the indication? What are the indications to report when you see a dengue child in a febrile phase and you are sending the child home? Educate and counsel the caretaker or the mother to report when there is any minor bleeding. Even you are on the lookout for any petechiae or purpura on the skin, any mild bleeding from the gums or nose, or if he is actually vomiting blood, or if he is having a black colored stool, or even if adolescent girls are having a heavy menstrual bleeding, you have to counsel the mother come back. Or the mother, the child is having a frequent vomit, not able to drink, which could be a warning sign. The child is having a persistent abdominal pain, which is also a warning sign. And these are the other indications. The child will be drowsy, lethargic, and the child will not feed. And this is the most common thing, like pale, cold, clammy skin, clammy hands and feet, because dengue shock is a hypovolemic shock, and that is actually a cold shock. You know what a cold shock is and a warm shock is. So in cold shock, your systemic vascular resistance is increasing to keep your BP at a normal level. I think all of you know your blood pressure is equal to the cardiac output into your systemic vascular resistance. And cardiac output is the stroke volume into heart rate. So stroke volume is again preload. So when you have a leak in the capillary permeability in dengue, the intravascular volume is gone, the preload is gone, the stroke volume decreases, the cardiac output decreases. So, in order to maintain the BP, the systemic vascular resistance will increase. So, that is the reason for an increased diastolic BP with a maintained systolic BP which you get in dengue, and that is a narrow pulse pressure you encounter in dengue, which is a cold shock. So, narrowness of pulse pressure is also an important obvious finding in dengue, which will be discussed in the coming. So, indication is that is I was explaining the reason for a cold extremities, which is due to the peripheral vasoconstriction due to increase in systemic vascular resistance in an attempt to maintain the then any tachypnea, because when there is a leak, the capillaries inside the lung also can leak, and there could be a ARDS like picture also sometimes, and postural dizziness. The mother should know when the child is suddenly getting up from the supine position, is he having dizziness? So that is also an early indication that the leak is ongoing, the leak is there. And this is also very important. If there is no urine output for 4 to 6 hours, that also indicates that the intravascular volume is. So definitely you have to counsel the mother regarding all these, and then only you need to send the patient if it is a case of. And this is a laboratory result also, which you can actually put it in a piece of paper, and you can give to the mother first visit. What was the date? What was the hematocrit? What was the total count, platelet count, and keep a serial monitoring of it, which will help us to know the time frame whether this patient is going into the critical phase. So this scenario is very important, and this is a case of a child with a dengue fever in the febrile phase. I hope it is clear. Now, these are the indications for refer, because uh, which cases you will refer. I have just incorporated this slide in between when I am discussing the dengue fever in the febrile phase. So, any warning sign, if you don't have a facility to have a bedside monitoring of the child, a 24-hour doctor should be present for monitoring a child with a warning sign. So if you don't have facilities for that, don't keep the child there, because dengue shock is a shock which has to have a hourly monitoring. It's the hemodynamic status and urine. So intense and persistent abdominal pain, persistent vomiting. If you don't have facility to give crystalloid and monitor what to refer, and there is an evidence of clinical fluid accumulation, like there is a air entry decreased on one side, it's a fluid extraction or an ascites. That means there is definitely leak is there in what to refer. If the child is complaining of extreme lethargy, restlessness, irritability, all these indicate that the blood flow to the brain is less, and any spontaneous bleeding from any side, that means that the vasculopathy is there, and absolutely no urine out for 6 hours. It's an indirect indication that the patient's leak has started and the intravascular volume is depleted. Have to refer. The patient is having cold shock with prolonged capillary fill, narrow pulse. This is very important. So suppose it is a bigger child, you find a BP, 10-year-old, 12-year-old child with 90 by 8. 90 is the systolic, 80 is the diastolic. We have seen children, lot of children with narrow pulse pressure. So that also is an indication that the leak is progressing and you want to refer. Okay, narrow pulse pressure means, our usual adult is 128. The pulse pressure is 40. Any pulse pressure less than 20 millimeters of mercury is narrow pulse pressure. Now, what are the other indications? If there is any organ involvement, immediately refer, because these children will do very bad, especially the dengue, myocarditis. If the LGBT, SGOT is above 1000, that is a severe dengue. If there is VNS alteration, confusion, seizures, evidence of dengue myocarditis in the form of shock, heart blocks, or rhythm abnormalities in the ECG. The hematological parameters prolonged, even with no bleed, you ought to refer. Pulmonary, like tachypnea, respiratory distress, hemoconcentration, you ought to refer. Then platelet count less than 30,000, even without a bleed, you ought to be very cautious. And that too, if the platelet count is rapidly falling. That means suppose you do the platelet count yesterday the platelet count was 1 lakh. Today you do it, it has reduced to more than 50%. That means from 1 lakh it has decreased 1,000 or less. That itself is very obvious that it has gone into the dengue capillary leak and the dengue shock. And of course, if the platelet count is less than 10,000, definitely you want to transfer, because you need to such case. If the platelet count is less than 1 lakh, even with the skin or mucous membrane bleed, you want to refer. So these are the clear-cut indications for referral of a dengue fever. Okay, now we'll come to the second scenario. So this is a 5-year-old female child with history of persistent vomiting and abdominal pain, and she had fever for 5 days, but since yesterday she is febrile. So this is the scenario. The 5-year-old female child and is weighing with a history of persistent vomiting and abdominal pain, and she's febrile too. So the ABC, what is the ABC? She is conscious and alert. She's having a normal breathing, no tachypnea, and her extremities are pink. Now come to your ABCDE. Anyway, airway is maintainable, but you find that the respiratory rate and the respiratory parameters and the pulse 92, good volume, capillary filling time is less than 2 seconds, and BP is maintained for a 5-year-old child. Alert, ABPU, she is alert and she is febrile. So this is the scenario. So what is it? This is scenario two, in which this is a 5-year-old female child, and child is having persistent vomiting and abdominal pain. In an epidemic of dengue, you always have to keep this DD in your mind, even if you don't have a NS1 or an IgM positivity. And you know, from yesterday she is febrile only. So we don't know whether these two symptoms are warning signs. So what are you going to do? You send a basic investigation when the child came to you. Hemoglobin is 13.4, PCV is 40, which is slightly hemo concentration for our Kerala children. Total count you see, definitely there is leukopenia 2400. The differential count 38 and then 52. Platelet count is 85,000. And you got the IgM report also as positive. So now there is no doubt. But what I was telling earlier is such a scenario child coming to you in an epidemic of dengue, you ought to consider the differential diagnosis, even though you don't have a serological or a antigen positivity. So this is clear. So what is this? So you know this is a dengue child which is having a warning sign. So I already told you what does warning signs indicate. It indicates that the capillary permeability has increased, the endotheliopathy has started, and the patient or the child has started to leak from within the intravascular compartment. So there is some fluid which is leaking outside into the interstitial compartment, and you need to fill up the intravascular compartment. So, because of persistent abdominal pain and the vomiting, the patient cannot have anything orally. So, you are going for your crystalloid. As I have already discussed, which is the crystalloid of choice, you ought to give normal saline. And how much normal saline you ought to give? Suppose a 5-year-old child is weighing 20 kg, you need to give 6 ml per kg per hour. Mind you, in dengue shock management, everything is in an hourly basis. Please never put it as 6th hourly, 4th hourly, and go off. That will create problems. It's also always an hourly basis. So 20 kg child, 6 into 20 will be 120 ml. You are going to give over 1 hour. Clear? So you have started this child on 120 ml of normal saline. Now what you ought to do? You ought to monitor the pulse volume, the BP, and respiratory rate. So suppose the child had tachycardia, or suppose the child had a low pulse volume, that means the child also has a compensated shock. BP is low. So once you hydrate intravascularly, the tachycardia will come down, the pulse volume will increase. So you ought to monitor the hemodynamic status, plus you ought to monitor the urine output. So urine output monitoring is very, very important in managing a dengue child. Since it's a 5-year-old child, she is alert and active. You can tell her to empty her bladder and you will monitor the urine output. You need not catheterize her, but you have to keep her eye on the urine output. Suppose hourly urination is not possible, at least she can void hourly. But if the urine output is not able, you are not able to have a guide on the urine output, don't hesitate to catheterize the child. So this is very important because without proper urine output, you cannot guide on the fluid management in dengue. Clear? So you are going to aim at a minimum urine output of 1 ml per kg per hour. That means if a child is 20 kg, she should have 20 ml of urine, that is 1 ml per kg in 1 hour she should have. So this is very important. And if the hemodynamic status is okay, if the urine output is okay, then what is it? Whatever fluid you are giving inside normal saline is now remaining within the intravascular compartment. That is what is your assumption. So now what do? You don't want any amount of fluid to leak into the interstitial space. So you can come down on your fluid requirement. You decrease it to 3 ml per kg per hour. Is it clear? Because we want the fluid to just maintain the hemodynamic status. Then what you do, if again your hemodynamic status and your urine output is good, you again decrease it to 1.5 ml per kg per hour. And if the child has, by now, usually the child is vomiting, and abdominal pain would have come down because I told you it is due to the splanchnic vasoconstriction. When you give fluid, the intravascular volume is depleted, so the symptoms also will decrease, and now the child can take orally. So this is the management of dengue with warning sign. But suppose it has not improved, the hemodynamic status has worsened. Previously, the pulse rate was 90. Now, after 6 ml per kg, the pulse has become 140. Pulse volume has become low. The patient has become tachypneic. What does it mean? Your 6 ml per kg is not adequate now. This child with a dengue warning sign has drifted into compensated shock. So, you have to increase the fluid from 6 ml per kg per hour to 10 ml per kg per hour. So hope this is clear. So this will be the scenario which you will encounter in the first line, like you have a child with a dengue warning sign, what to do and how to proceed. Now, so what is it? You need a proper hemodynamic monitoring. I have already told you. You have to have a strict monitoring of urine output. You have to check the hematocrit because with your fluid, you ought to know whether the hematocrit is coming down. So if the hemodynamic status is improving and the hematocrit is coming down, that means your intravascular volume you are adequately treated. Random hematocrit has got no value. You should always do the hematocrit after you have given an adequate repletion. And one important thing which you have to consider is that you should never increase the fluid therapy in a well perfused child based only on a high. I think that is the thing which we all do. We are panicked at the increasing PCV. Even though the hemodynamic status and urine output is okay, we increase the fluid. Never do that. Because once you increase the fluid, the excess fluid will leak into the interstitium and everything will come back in the recovery phase and you will have problems in the recovery phase. So this is what is called as the three-dimensional monitoring. Keep an eye on the hemodynamic status. Urine output has to be monitored judiciously, and then you are going to decide on your fluid. So this has to be done. So this is the scenario like suppose you give a fluid and you look at the PCV. So it can be a scenario of a persistent rise in PCV, or you feel that the PCV is decreasing. Suppose there is a child who has come with the dengue with warning sign or a dengue compensated shock, and you have given a steroid of 10 ml per kg in 1 hour. Now you are repeating the PCV. You find that the PCV is decreasing. But along with the decreasing PCV, you have a stable vitals. What is stable vitals? The hemodynamic status is normal. The urine output is normal. That means that is the case has improved. You have rehydrated the child. But in a scenario of a decreasing PCV with an unstable vitals, that indicates that there is a major bleeding and you have to order for a blood transfusion. Now coming to the upper thing, like you have given a crystalloid 10 ml per kg, and but you repeated the PCV, the PCV is high. So what does it mean? You have to look at the vitals. If the vitals are stable, hemodynamic status is normal, urine output is normal, you can wait. You need not give extra fluids. You can even give oral fluid if the child is having no vomiting and abdominal pain. But in a scenario of a persistent increased PCV despite a crystalloid with an unstable hemodynamic status means that the fluid is leaking, the fluid you are giving is that's not enough. You need to increase your fluid, whatever you are giving. If it is 6 ml, increase to 10 ml. If it is 10 ml and the child has gone into shock, profound shock, you have to make it 20 ml. So this is the three-dimensional monitoring you are going to do. And this point you always have to never increase the fluid therapy in a well-perfused child only based on the hematocrit value. Okay. So now it is the scenario 3. This is a 10-year-old obese child who was weighing weight is very high for his age, 54 kg, brought to the casualty with history of fever, headache, and vomiting. And he is now lethargic, and the mother feels that his extremities are cold. So this is the scenario. And look at the ABC and ABC. He is drowsy. The child is drowsy. The child is having tachypnea, but he is pink. Airway is maintainable. Now he is tachypnic. His pulse rate is tachycardia. He has got a low volume pulse. Capillary filling time is prolonged. BP is 90 by 76. Of the 10-year-old child with a 90 by 76 BP is a narrow pulse pressure. And he is having a prolonged capillary fill, tachycardia, low volume pulse, tachypnea. So he is in compensated shock. So this is possibly a child who is having a dengue with the compensated shock. So you got with baseline hemoglobin 15.3 with the raised hematocrit of 48. Total count is 1840. The platelet is 45,000. So what is this? This is a child who is having a narrow pulse pressure, child who is having a compensated shock, and the child, even though he is even in a hypotensive shock with a normal pulse, everything together is taken as one slot for managing the child. All these conditions, you are going to rehydrate the child with normal saline 10 ml per kg. You are going to give over 1 hour. Understood. So that is why I told the importance of pulse pressure. So even with a narrow pulse pressure, you ought to follow this algorithm. Narrow pulse pressure, compensated shock, and even a hypotensive shock with the normal palpable pulse. All the three are having the same management. You are going to give IV fluid, normal saline, 10 ml per kg over 1. Then you are going to look for the PCV. Plus, I told you three-dimensional monitoring. Look at the PCV, look at the hemodynamic status, and look at the improvement. So, if there is no improvement in the hemodynamic status and the PCV is right, what does it mean? The fluid you are giving is not sufficient. So, you have to give one more dose of 10 ml per kg over 1 hour. Even if that is not adequate, you have to give repeat it once more. So 10 ml per kg, 10 ml per kg, 10 ml per kg. All you have to give over 1 hour, you can give up to 3 times. So if still you feel that there is no improvement, hemodynamically the child is still tachycardic, tachypneic, low volume pulse with narrow pulse pressure. When you do a laboratory investigation, the PCV is right. This is very obvious for the children. So what you ought to do, if there is no improvement with the rising peak, with a no improvement with a falling peak, immediately you want to give a suspect a bleed and give a blood transfusion. Okay, it will go that way. Suppose these, that is, you have given crystalloid 10 ml per kg and there is an improvement with 1 dose or 3 doses, then you can actually taper your food. But even with 10 ml per kg, 3 times, the patient is not improving, you should immediately refer the child. Don't have facility for closely monitoring him, and you have to consider it as a case of severe dengue because he already has received 30 ml per kg of crystal. So I hope it is understood. This is the same flow chart for all the three together: compensated shock, narrow pulse pressure, and hypotension with a palpable pulse. Okay. So now we'll come to dengue shock syndrome. Dengue shock, it can be like I already told you, the BP can be low, so it can be a hypotensive shock. Or it could be just by a narrowing of the pulse pressure, which is less than 20. Or as I have told you, we had many children coming up with even absent peripheral pulse and even undetectable BP. So that is also a type of dengue shock. And even the children can come with a compensated shock. So these are the different forms of dengue shock which you can encounter in children. Okay, so now we'll come to the compensated shock. Compensated shock also, you should have a high index of suspicion in this epidemic. even though you are not having a serological or an antigen diagnosis of dengue, because compensated to manage timely, that otherwise the patient can respond to decompensated shock and cardiac arrest. And in this scenario, early blood transfusion can be given if, with in spite of crystalloid and colloid, you have a normal oral increased PCV with an unstable hemodynamic. So this is an indication of blood transfusion in a compensated shock. And as I have told you, uncorrected shock, prolonged shock, metabolic acidosis is a major cause of coagulopathy and bleed in dengue. So if you correct the compensated shock early, you can correct the metabolic acidosis, you can support the systems and prevent multi-organ damage. And one important point here, though the child is 10 years, is weighing 54 kg. So never calculate the fluid based on the weight of the child when the child is weak. It is ideal to calculate it by the weight for height, or even if that is coming to be on the higher side, calculate the fluid according to weight for age. Why again? You don't want unnecessary large amount of fluid to be given in the critical phase, because excess fluid will only seep out into the interstitial compartment and can later cause problem in the recovery phase. Okay. Now, how is this dengue shock different from other? So we have already pointed out, if there is a case of shock, you give 20 ml per kg of fluid over 20 minutes, any other shock. But in dengue shock, you would have understood that you are giving only a smaller volume of fluid. So I told you the previous case, you are giving only 10 ml per kg over 1 hour, and you are giving only 10 ml, and you are giving it over prolonged time. Fluids are given at lower rate, and you are going to vigilantly monitor the vital hemodynamic parameters, the hematocrit, and the urine output. And usually, inotropes are not necessary in dengue unless it's of refractory hypotension. So you have to give smaller volume of fluid at lower rate. Otherwise, what will happen? The fluid will, and with a minimum urine output of ml per kg per hour and stable hemodynamics, excess fluid will unnecessarily seep into the interstitium, and it will create problem in the recovery phase. So now this is another case. That a 7-year-old child was admitted in the ward with dengue with morning sign. The postgraduate has seen the case and has started the child on 6 ml per kg normal saline, and he has entrusted the house surgeon to look after the case. So he has put an hourly fluid, and the house surgeon reports to the PT 2 hours, and he tells that the PT that the child is bit double. And now the doctor shows the child is having an altered sensorium, the child is having a feeble pulse, and the BP is not recordable. So this can happen because once the child has been in dengue, the capillary permeability is increased and the permeability has started to occur, you should have a very vigilant monitoring. Otherwise, the leak can be so fast that your 6 ml per kg of saline, which you had given for warning sign, child can even suddenly progress to your profound shock. So this is a child who was having profound shock with absent pulse and non-recordable BP. So what you have to give? So now, since it is an absent pulse profound shock, your fluid requirement has increased to 20 ml per kg. But mind you, here also we are giving it only over 1 hour. You are not pushing it over 20 minutes as in other forms of shock. And you are going to repeat the crystalloid. Crystalloid is always preferred as the initial modality. You reserve the colloids only if it is not possible to maintain the intravascular volume with a crystalloid, because colloids have got its own disadvantages, and colloids cannot be given above 30 ml per kg in a single day. So you have repeated 20 ml per kg of crystalloids for 1 hour. 2 crystalloids have been given, and now you are always monitoring the PCV. So suppose the PCV is still high, you can repeat a third steroid of 20 ml per kg. Suppose you repeated the PCV and the PCV is low, that means there is an internal bleeding and you want to give blood transfusion. Now, even with 3 crystalloids of 20 ml per kg in 1 hour, still the PCV is high, the patient has not improved. Here comes the role of colloids. Now you give a colloid which is 10 ml per kg and you repeat the PCV. PCV is still high, you can repeat another colloid of 10 ml per kg. So here comes the role of colloids in managing a case of dengue shock. And you have to monitor the vitals every 15 minutes. And once the pulse has appeared, immediately decrease the fluid to 10 ml per kg. So this is always, we are always bothered about the required fluid. You are aiming at not even giving fluid unnecessary, even if the patient is in shock. Like the patient had a absent pulse, but once the pulse returns, you decrease the fluid from 20 ml per kg to 10 ml per kg. Okay. So what is the indication? What are the indications for colloid? So what does this colloid do is when there is a colloid, the aquatic pressure is going to increase within the intravascular compartment, and whatever fluid was present in the interstitial space is going to come back. So that is called as reverse osmosis. So when there is a persistent shock, despite of receiving so much of crystalloid, there is an indication to give a colloid. So some cases you will see like the patient might have been treated somewhere else with lot of crystalloid, and all these crystalloid would have caused the periorbital puffiness, ascites, and pleural effusion. So now, and the hemodynamic status is not good. Now you cannot give further crystalloid. So you can give a colloid if there are signs of shock with signs of fluid. And already the child is puffy due to so much of steroid, again you can give colloid. So which colloid you give? So the colloid preferred is dexpan 40 and the dose is 10 ml per kg. And usually it is said that the 10 ml per kg of dexpan 40 can decrease the PCV by 10 points. If the PCV is decreasing more than that, along with an unstable hemodynamic status, consider bleed and give blood transfusion. If there is no improvement with the first dose of colloid, you can repeat the second dose of colloid. But you should always limit the colloid to 30 ml per kg. And Dextran also will interfere with grouping and cosmetic. So it is ideal that once you get a dengue child with a dengue vascular permeability with warning signs found, it is preferable to take a sample to grouping and cosmetic earlier and keep it in the fridge so that if need arises for blood transfusion, you can use it. Because if you have given a colloid expand, sometimes it can interfere with your grouping and there is another situation in which you give lot of colloids. Sometimes the colloid can also leak into the interstitium. So colloid in the interstitium will again pull out fluid from the intravascular compartment. So it is actually like you have to weigh both. You have to weigh both the problems of extravasation and intravasation, and you have to decide accordingly. So now there is a term called refractory shock. So before branding a child as refractory shock, you have to give attention to A, B, C, D. A is your acidosis. You will remember that I have told in my previous talk that acidosis is the one which is paving for the plague. So only in dengue fever, a dengue shock situation, if the pH is less than 7.3 or if the bicarb is less than 15, you ought to give a bicarbonate of 1 ml per kg because acidosis is paving for coagulopathy and bleed. This is mandatory in dengue fever, and unlike in other acidosis, no, bicarbonate is actually contraindicated in other acidosis, but you ought to give bicarbonate in dengue. Then the other thing is the shock in dengue, as I have told, the major cause of shock in dengue is a hypovolemic shock. because capillary permeability is increasing and fluid is leaking outside. So the intravascular volume is low and you get a hypovolemic shock. But suppose a dengue child is bleeding, you can get a hemorrhagic shock also. So in that situation, immediate blood transfusion followed by platelet and be needed in that case. Shock in dengue can also be cardiogenic shock in a situation of a dengue myocarditis, in which case you have to give inotropic therapy. It could be also neurogenic shock in a case of dengue encephalitis, and this neurogenic shock is usually a wide pulse pressure shock, and here the inotrope of choice is noradrenaline. And in some cases, in dengue, you can get an associated septic shock, especially if the dengue child was to die. And he can get a nosocomial infection. So, refractory shock. What are the indications for inotropes in dengue? So, inotropes can be given in dengue in case of refractory shock. It can be given as a temporary measure to prevent life-threatening hypotension. It can be given as a temporary measure in injection of intubation. And if there is evidence of cardiogenic shock, you ought to give a drop. And the preferred inotrope with a normal BP is dobutamine, and with a low BP is adrenaline. And in case of a wide pulse pressure shock, as in dengue encephalitis or dengue hepatitis, the inotrope of choice is noradrenaline. And in cases in which there is a worsening acidosis, not responding to blood transfusion, also you ought to give an iron. So you ought to know that inotropes are not indicated in dengue in the instances because mainly the shock is due to a hypovolemic shock due to the extravasation from the intravascular compartment. You are trying to maintain the intravascular volume with your crystalloids or colloids or blood. So indication for inotropes is only in cases of these many conditions of shock. Now, calcium is going to have an important role in dengue because see, calcium is important for coagulation and calcium is also important for the good contractility of the heart. And so, if it is a documented hypocalcemia, is there, the calcium is actually acting as an inotrope of the heart. So, if there is a document hypocalcemia, you can give calcium as a calcium injection, 0.1 to 0.2 ml per kg per hour. And sugars also you want to keep into consideration. If hypoglycemia is there, you have to manage with gluten and followed by DNS, especially in a patient who is having bleed or a GI bleed, which the oral intake is not possible. Now there is something called dengue panic syndrome. Anybody what is dengue panic syndrome? Dengue panic syndrome is you are panicking by the platelet count in dengue. And I told you, don't panic unnecessarily and unnecessarily don't give platelet transfusion in dengue because thrombocytopenia is not a major cause of plague. So if you give platelet transfusion unnecessarily in dengue, it will cause platelet addition and aggregation, leading to microthrombi formation. Because I told you already the endothelium is dysfunction. There is an endothelial infiltration of platelets, and these platelets will adhere to the endothelium, aggregate with the endothelium, and it will lead to microthrombi formation. And in the setting of hemo concentration, this microthrombi will add to the sluggish circulation and it will lead to worsening of multi-organ syndrome. So this you ought to always remember. Don't give unnecessary platelet transfusions in dengue because you are adding to the multi-organ dysfunction. Now there is an entity like in any infections, they can progress to what is called as HLH or the hemophagocytic lymphocytosis. Suppose the dengue patient, the fever is persisting, you ought to think of two conditions. One is secondary bacterial infection, because the patient was treated for dengue shock, prolonged in the hospital, sometimes would have acquired a nosocomial infection. So you ought to do a procal blood culture, and some days you have to escalate the antibiotics accordingly, depending upon the culture and sensitivity of the organisms prevailing in your system. But sometimes we have even seen cases of co-infection of dengue with leptospirosis and also co-infection of dengue with scrub, in which case you ought to add the antibiotics accordingly. And another situation in which a dengue child was become like of the shock, and the patient is running a high fever with worsening cytopenia, organomic health, decreasing ESR, you ought to think about the condition of a hemophagocytic lymphohistiocytosis, secondary HLH, secondary to dengue. In that case, you have to give IVIG or steroids. Okay, I think this is another scenario. 11-year-old child was admitted in your ICU and he was managed for dengue shock syndrome with crystalloid, colloid. You had given blood transfusion, platelets, and FFP because he was a sick case of dengue shock syndrome. And now you find that he is having high BP. So, what is it? So, this was the issue which I was talking about earlier. So he's tachypnic now, he's pink, he's alert, the airway is maintainable, he's having a respiratory rate, desaturation, lungs is showing bilateral repetitions. Now pulse is 110 with a bounding pulse, capillary fill is prolonged, blood pressure is on the higher side, he's alert and he's affected. So what is the situation? So this is situation which can arise in situations when you ought to give lot of colloids, steroids, blood, etc. during his critical phase. And I told you it can leak into the interstitial compartment and can remain there. And when the child is showing a recovery phase, all these can come back into the intravascular compartment and present with features of congestive cardiac failure. So this is a case who has gone into the recovery phase with complications with features of cardiac failure. So, how do you recognize a congestive phase? The patient who had initially who had presented with a poor peripheral pulse now has a bounding pulse, rising BP. The ascites has resumed. Patient has an increasing urine output, and because of the fluid, patient has a decrease. The patient can even progress to pulmonary edema. So, how you can prevent this? You want to keep a judicious fluid administration. Just administer all the fluid blood products to maintain an effective circulation only and maintain a minimum urine output of 0.5 to 1 ml per kg per hour. And as I told you, avoid blood and blood product transfusions unnecessarily non-bleeding patients. But you have to recognize proper recognition of the recovery phase and you have to sustain the intravenous fluid you are giving. And now how you are going to proceed? Proceed, you have to stop the intravenous fluid. So you can put in a continuous low dose Lasix infusion of 0.1 mg per kg per hour. You can start a non-invasive ventilation with a high peak. And if the patient is still desaturating with pulmonary edema, you have to plan for an invasive ventilation. Now, these are the point of care ultrasound you can do in situations or places where you have permission for doing an ultrasound. That is the bedside ultrasound, which can pick up the fluid, gallbladder wall changes, the IVP collapsibility, the cardiac contractility, and the pulmonary edema. And this point of care ultrasound is very important in the bedside management of critically ill dengue patients. So this is a gallbladder triangle which you can see when there is a fluid leaking into the interstitium of the gallbladder. This is the collapsible IVC which you can see, and this is the IVC you can see. And cardiac contractility can also be recorded because cases of dengue myocarditis can have a low cardiac contractility. And you can pick up the pulmonary edema by doing a bedside lung ultrasound and picking up the B lines. Left side is the normal A lines. You can see this one. These are the normal A lines in the lung ultrasound. And when there is pulmonary edema, you can see the long lines which are cutting across the lung field, which are the B lines. B lines indicate pulmonary edema, and that is warning us that the fluid you are giving is more and you need to might be given. Now, what are the indications for ventilation in dengue? Indication for mechanical ventilation when the patient is in refractory shock, patient has got pulmonary edema, patient has got capillary leak within the lung, that is ARDS, when there is a failure of lung. So, you have to consider NIV early in the course of disease. The child has got a respiratory fever and the shock is not responsive to your fluid. So in facilities where NIV is there, or even if NIV is not there, you consider use the CPAP. Now ventilation in dengue needs for experienced personnel should be there. Sedation and analgesia should be used in caution because hypotension or cancer. Don't use metabolic muscle relaxants because it can precipitate an arrest between the compensation, because the child had tachypnea in order to compensate for the metabolic acidosis by walking on the carbon. So you cannot give a muscle relaxant because that will stop the compensation, worsen the metabolic acidosis, and it can pay for metabolic acidosis can pay for coagulopathy. And you have to be very careful in putting the tube because trauma can cause bleeding. In a scenario of a refractive shock with a metabolic acidosis. So if the patient is in shock, you can start with IV fluids or even can give iron drop. And sometimes you need to go to higher pressure because of the pleural expansion. Higher PEEP is also required because of pulmonary edema and ARDS. But you should be always careful that you keep the ventilator rate according to the rate of the child. Because if the child has tachypnea, keep the ventilator rate at the same rate, otherwise child can, because as the circulation improves, only the metabolic acidosis will decrease and you have to adjust the technique. So this is very important. Once you ventilate the child, ventilate according to the pre-ventilation rate, keep the rate at that rate only. Okay. So now this is a case to show the importance of infant dengue, because infant dengue is having a very high mortality. It's an 8-month-old infant presented with fever of 2 days duration with one episode of generalized tonic-clonic convulsion. Examination, the child is febrile and the anterior fontanelle is full, generalized flushing, pulse tachycardia but with volume, capillary filling time normal. The baby is not tachypneic with a normal beat. And investigation shows PCV of 30, platelet of 1.2, total count of 3,000, CRP is negative. So you are thinking like it's an 8-month-old infant where tonic convulsions, AF full, will be a septic meningitis. So PRP has come as negative and your dengue illness body form. So this is to highlight the fact that infant dengue can have the same presentation as the septic meningitis, but the CRP is negative. This is the flushing you see dengue. And infant dengue has got a higher mortality and morbidity. It's a high risk group, and it is because of the already acquisition of maternal antibodies from the mother. You get a second dengue viral infection, you get a secondary dengue, which is more severe. And infant has got more body water, so you need more vigilant fluid balance. Capillary beds are more permeable, leading to more severe problems. And another thing is infant dengue can present with upper respiratory symptoms, diarrhea and febrile condition. So don't confuse with sepsis and meningitis because it can mimic the sepsis. This was an infant dengue which required a prolonged hospital stay for about 1 month, but discharged without any morbidity. And this is the dengue monitoring chart. I think this scenario is like even in cases of an epidemic of dengue, can even get a newborn with a dengue. So in order to just concentrate on that, this is a case which we had got in our NICU during 2018. This was a term neonate 2.5 kg KB Dhaka. The mother had fever and myalgia 5 days before delivery. and had mildly elevated liver enzymes and dengue IgM was positive for the mother. Baby was admitted in the ICU on day one because of risk factor. The risk factor was the elder sibling had died in the newborn period due to bilirubin encephalopathy because of OA incompatibility. So this was the newborn on postnatal day 3 developed fever and was feeding. Sex screen was negative. The newborn had associated rash, leukopenia, platelet count, and SDBT and OT were elevated. NS1 was positive for the baby, and the baby was given supportive treatment with IV fluids, and the baby recovered. And on postnatal day 10, the platelet counts increased 1.4. So this is to highlight the importance of vertical transmission in dengue viral infection. So transmission can occur from the pregnant mother to the fetus, and more chance if the mother develops dengue a few days prior to delivery. And onset of symptoms in the newborn to range from 1 to even 12 days. Usually, the newborn will present with fever, rash, cytopenia, and sometimes it can have a catastrophic presentation with GI bleed, effusions, shock, and even intracranial hemorrhage. So the thing is, even with absent maternal history, newborns who are presenting with fever, thrombocytopenia, and bleeding manifestations the first day of life, even in the first day of life, or subsequent to that, neonatal dengue has to be considered in a scenario of a dengue. So increased awareness and identification to prevent the development of complications. So National Dengue Day is celebrated worldwide in our country on 16th of May 2023. And the theme for 2022 was Be Protective and Defend Against Dengue. 2023 theme was Fight Dengue and Save Life.